Welcome to Deep Dive Ortho. Today we're taking a really close look at a surprisingly common, yet often quite critical, injury.
Mm.
Collateral ligament tears of the thumb.
hmm
Now, these might seem like small injuries, but they can have a profound impact on overall hand function, can't they? Affecting everything from, well, grasping a cup to intricate surgical work.
Absolutely.
You might know them by names like skier's thumb or gamekeeper's thumb, but there's actually a whole spectrum here, isn't there? From subtle partial tears right up to complex ruptures needing precise surgery.
That's right. There's a lot more to it.
And joining us to shed light on these intricacies and guide us through their optimal management is Professor Mo Imam, a distinguished expert in this field.
Thank you. It's always a pleasure to discuss an area so fundamental, really, to preserving thumb stability and, well, by extension, overall hand dexterity.
Hmm.
The collateral ligaments of the thumb, particularly the ulnar collateral ligament, or UCL, they're vital structures. And understanding their injury patterns and the optimal management strategies is truly key for any practitioner, I think,
Yeah.
given the thumb's crucial role in, well, almost everything we do.
I couldn't agree more. So, to really get to grips with the potential impact here, let's start with the fundamentals, shall we?
Good idea.
Could you walk us through the intricate anatomy of the thumb's collateral ligaments and maybe detail precisely how they typically get damaged?
Certainly. Well, the thumb, it appears quite simple, but it's actually a marvel of biomechanical engineering.
Hmm.
You've got the three bones, the metacarpal, proximal phalanx, distal phalanx, and the two key joints.
Yeah.
Our main focus today is on the metacarpophalangeal joint, the MCP joints.
Okay, the MCP, the knuckle joint.
That's the one. Right at the base of the thumb, near the palm, in that crucial web space between the thumb and index finger.
Got it.
And that's where the vast majority of these collateral ligament injuries occur.
Okay.
Now, flanking this MCP joint are the collateral ligaments themselves.
Yeah.
The ulnar collateral ligament, the UCL, on the side closest to the index finger. Right. And the radial collateral ligament, or RCL, on the opposite side towards the wrist.
Okay.
These are strong, dense bands of fibrous tissue connecting the metacarpal to the proximal phalanx. They provide crucial stability against sideways forces.
Sideways forces, okay.
And what's particularly interesting, I think, is that both the UCL and RCL have two main parts. There's the proper collateral ligament, which is tight and resists forces mainly when the thumb and CP is bent, in flexion.
Right.
And then there's the accessory collateral ligament along with the volar plate, which resists load when the thumb is straight, in extension.
Ah, okay, so different parts work at different angles.
Exactly. And they run slightly from the back towards the palm, sort of dorsal to volar, as they go from the metacarpal to the phalanx.
Hmm.
This specific layout dictates their function through the joint's movement.
Fascinating. So how do they get injured? What are the common mechanisms?
Well, the UCL is injured far more often than the RCL, about 10 times more frequently, actually.
10 times. Wow, why is that?
It's largely down to the thumb's biomechanics and common injury patterns. A UCL injury often results from a forceful radially directed hyperabduction, basically the thumb being forced aggressively away from the palm.
Like bending it back too far sideways.
Precisely, into an excessive L-shape, if you like.
Mm-hmm.
And the ligament typically fails right at its distal attachment, where it connects to the base of the proximal phalanx.
Okay.
Or sometimes it pulls off a small piece of bone from that insertion point and a Volscian fracture.
Right, I see.
Now, the classic scenario everyone mentions is the skier's thumb,
Yes.
falling onto an outstretched hand while gripping a ski pole, hyperabducting the thumb.
The pole acts as a lever, doesn't it?
Exactly. But it's really important to recognize that actual skiing accidents only account for a relatively small percentage of these injuries.
Oh, really?
Yes. Studies show over 49% are simply due to a fall onto an outstretched hand, just a trip or slip landing awkwardly.
So nearly half are just simple falls.
That's right. And then other ball and contact sports, things like football, rugby, basketball, even volleyball, are significant contributors too. A direct hit, an awkward catch.
Anything that forces the thumb back suddenly.
Correct. In fact, UCL injuries alone make up something like 86% of all athletic thumb injuries. So they're very common in sports.
That's a huge percentage.
It is. And then, distinct from that acute injury, we have what's known as gamekeeper's thumb.
Right, the chronic one.
Exactly. This typically refers to a chronic condition developing over time, from repeated, low-grade hyperabduction or repetitive grasping and twisting activities.
Like the name suggests, from the old gamekeepers.
Precisely. You can imagine them repeatedly performing certain tasks, maybe twisting the necks of small animals or carrying game. These repetitive valgus forces gradually stretch and lengthen the ligament over time,
So it's not a sudden tear, but a gradual wearing out.
leading to attenuation and chronic instability rather than an acute rupture. And that chronic laxity can be incredibly debilitating, causing pain and weakness, especially with pinching.
That distinction between the acute skier's thumb and the chronic gamekeeper's thumb seems really crucial then for understanding how the patient presents and I suppose how we manage them.
Absolutely crucial.
So, given this spectrum, from that sudden trauma to the chronic degeneration, how do we actually classify these injuries clinically? And what are the specific implications of each grade?
Right. Well, we use a standardized grading system. It classifies the severity of the sprain,
Yeah.
and this directly guides our management.
Makes sense.
And getting this classification right is absolutely critical because the wrong assessment can definitely lead to suboptimal outcomes and long-term problems for the patient.
Okay, so what are the grades?
So grade 1 signifies a mild sprain. Here, the ligament has been overstretched, but it's still intact. There's no significant macroscopic tear.
So just a stretch, essentially.
Yes. Patients typically present with localized pain or tenderness, often a dull ache, maybe some swelling, sometimes bruising around the base of the thumb. Interestingly, the initial pain at the moment of injury can sometimes be surprisingly mild. It might only worsen as the inflammation kicks in later.
Ah, right.
But crucially, on clinical examination, the joint is stable. That's the key differentiator.
Yeah.
There's no pathological laxity when you stress it.
Stability is maintained. Okay, grade 2.
Grade 2 indicates a moderate sprain. Here, the ligament is partially torn. Some fibers have ruptured, but a significant portion is still intact.
A partial tear.
Correct. So patients with grade 2 injuries will have more pronounced symptoms, more pain, more noticeable swelling, often significant bruising that might track along the thumb.
Okay.
They'll also experience limited function and range of motion. Now, on examination, you'll typically find some asymmetric joint laxity when you compare it to the uninjured side.
So it feels a bit looser.
A bit looser, yes.
Yeah.
But here's the critical point. There's still a discernible, firm endpoint when you apply stress.
Ah, okay. There's still some resistance.
Exactly. The damaged ligament is still providing some resistance, even though it's diminished.
Right. And grade 3.
Grade 3 is the most severe. This represents a complete tear of a ligament, or its complete detachment from the bone, sometimes with a small bone fragment that avulsion fracture again.
A full rupture.
Yes. These often present with intense pain and tenderness, although sometimes, surprisingly, the pain might feel less than a grade 2 once the initial acute phase passes. But the key sign is a noticeably loose or overtly unstable thumb MCP joint.
Okay. Significant instability.
Definitely. Patients will report real difficulty grasping objects, particularly that crucial precision pinch between the thumb and index finger.
Right.
And a particularly telling, really critical sign for a grade 3 injury, especially UCL rupture, is if you can feel a palpable lump at the base of the thumb on the ulnar side.
A lump. What's that indicate?
This is a critical indicator. It can actually be the ruptured and retracted end of the ulnar collateral ligament. It suggests a Steiner lesion.
Ah, the Steiner lesion. You mentioned that earlier. That sounds really significant.
Yeah.
When you talk about the adductor aponeurosis blocking healing, could you elaborate on that? What exactly is the Steiner lesion?
Yes, it's an excellent point to focus on. The Steiner lesion truly represents a unique and critical pathoanatomy of the UCL. It makes it quite distinct from many other ligament injuries.
Okay.
So imagine the adductor aponeurosis. It's a broad, thick, fibrous sheet, essentially a flattened tendon of one of the thumb's most powerful muscles, the adductor polliceus, and it runs right across the MCP joint.
Right, like a sheath over the joint.
Exactly. Now, in a Steiner lesion, the avulsed UCL, meaning the ligament torn completely off its bone attachment, maybe with a bit of bone, maybe not, it displaces, it flips up and over this adductor aponeurosis.
So it gets trapped on top of it.
Precisely. It ends up lying dorsal and superficial to the aponeurosis.
And the consequence of that is?
Profound. This interposed aponeurosis physically prevents the torn ligament ends from coming back together,
Yeah.
from coapting.
Like something stuck in a doorway.
Exactly like that. It prevents the ends aligning and touching. So spontaneous healing simply cannot happen without surgery.
Right, it's mechanically blocked.
Completely blocked. And it's estimated to be present in over 80% of complete UCL ruptures.
80%. That's incredibly common in full tears.
It is, which is why early recognition is absolutely crucial for any clinician assessing these injuries.
And if it's missed, what's the typical outcome for the patient down the line?
If a Steiner lesion is missed, the real-world consequence is almost inevitably chronic instability of that thumb MCP joint.
So a permanently loose, weak thumb.
Yes, it remains loose, weak, leading to persistent pain, definite weakness with pinch and grasp, and significant functional disability in daily activities.
That sounds very debilitating.
It is. And over time, this chronic instability often leads to degenerative arthritis developing in the joint, which adds another layer of problems.
Right.
Plus, if treatment is delayed, the displaced ligament scars up in that abnormal position. This can make it unrepairable later on, meaning a simple primary repair isn't possible anymore. You then need a more complex ligament reconstruction.
Which really underscores why getting that initial diagnosis spot on is so vital.
Absolutely vital.
So that leads us perfectly into the diagnostic pathway. Given these variations in severity and the critical implications, especially of a Steiner lesion, could you detail the key steps in assessing a patient with a suspected thumb collateral ligament injury?
Of course. The diagnostic process, well, like any musculoskeletal injury, it begins with a meticulous history.
Right, listening to the patient's story.
Exactly. We need to understand the exact mechanism, the direction and magnitude of the force applied. Was it sudden, acute, like a fall?
The skier's thumb scenario?
Or was it more chronic, repetitive stress?
The gamekeeper's thumb?
Precisely. This helps differentiate and influences the plan. We also need to ask about the initial pain, the swelling, any immediate functional problems.
Okay.
History first, then.
Then, a careful physical examination is paramount. We start with visual inspection, although obvious deformity is rare.
Right.
Then, we systematically palpate the thumb. Gentle pressure around the MCP joint, paying close attention to the site of maximal tenderness.
Finding the sore spot. Exactly. For a UCL injury, it's typically right at the distal attachment onto the base of the proximal phalanx.
Okay.
However, if a Steiner lesion is present, that tender spot might actually be more proximal, further up towards the palm.
Where the retracted ligament has ended up?
Correct. And you might even feel that distinct, tender lump we talked about, confirming the suspicion. For an RCL injury, naturally, the tenderness would be on the radial side.
Makes sense. And the stress testing.
Ah, yes, the cornerstone of the physical exam,
Right.
the radial ulnar stress test. This needs to be done carefully.
How so?
We test the MCP joint in two crucial positions. First, in full extension, straight.
Okay.
And then, importantly, in about 30 degrees of flexion, so slightly bent.
Why both positions?
Because instability, mainly in 30 degrees of flexion, specifically points to an injury of the proper UCL, as that part is taut in flexion.
Right.
Whereas instability, also present in full extension, suggests injury to both the accessory and proper UCL, and possibly the volar plate too. It indicates a more extensive injury.
I see. It helps localize the damage.
Precisely. And comparing the injured thumb to the contralateral uninjured thumb is absolutely vital.
Always compare it to the other side?
Always. We're looking for increased opening, maybe more than 10-15 degrees compared to the unaffected side, or, critically, a complete absence of a solid endpoint, that mushy feel.
Indicating a full rupture.
Yes. Now, sometimes pain can cause the patient to guard, to tense up their muscles, masking the true instability.
Right. They resist the movement.
Exactly. In such cases, administering a small amount of local anesthetic into the joint can eliminate the pain, relax the muscle.
Ah, okay. Like a diagnostic block.
Precisely. It allows for a much more accurate assessment of the true instability. Finally, we also assess active and resisted pinch strength. That's often significantly weakened in UCL tears because of the lost stability.
Okay, history, palpation, stress test, pinch strength. What about imaging?
Imaging, yes. Radiographs, plain X-rays are always the first step.
Why x-rays? Ligaments don't show up, do they?
They don't show the ligaments directly, no. But they're crucial to rule out a fracture, particularly an avulsion fracture, where that small piece of bone is pulled off by the ligament.
Right. You need to see if bone is involved.
Exactly. And if you see a markedly displaced avulsion fragment, that immediately signals the need for surgical reduction, because that fragment and the attached ligament might also be blocked by the adductor aponeurosis, preventing healing.
So a displaced avulsion can imply a Stener-type situation, too.
It certainly can. We also look for subtle signs on X-ray, like the sag sign, a slight rotation of the proximal phalanx in UCL injuries, or volar subluxation on a lateral view, suggesting other associated damage.
Okay. X-rays first. What if they're normal? Or the exam is still unclear?
Right. If the clinical exam is equivocal, or if we strongly suspect a complete tear, or especially a Steiner lesion, then advanced imaging becomes crucial.
MRI. Ultrasound.
MRI is widely considered the gold standard here.
Okay. Why MRI?
It offers almost 100% sensitivity and specificity for visualizing both the bone detail and, critically, the soft tissue structures. It lets us confirm the extent of the tear. Is it partial? Is it complete? And crucially, it can precisely identify a Steiner lesion.
Which is vital for surgical planning.
Absolutely.
Hmm.
Musculoskeletal ultrasound can also be highly effective.
Ultrasound, how does that compare?
It's particularly good for dynamic assessment. You can stress the joint while imaging and see the ligament laxity or displacement in real time. It's also good for visualizing fluid collections. However, its accuracy is very operator dependent.
Right. Needs an experienced hand.
Definitely. So these advanced imaging modalities provide the detailed information needed to make really informed treatment decisions, especially regarding the need for surgical referral. It's that combination: meticulous history, thorough physical exam, and targeted imaging. That's the backbone of an accurate diagnosis.
That comprehensive pathway really underscores the importance of precision here. It's clear that getting the diagnosis right really determines the path forward, doesn't it?
It really does.
So once that diagnosis is established, particularly for the less severe injuries, non-operative management often comes into play.
That's right.
What does that typically involve? And for which grades of injury is it most appropriate?
Well, non-operative management is definitely the cornerstone for grade 1 and grade 2 partial UCL and RCL tears.
The sprains and partial tears.
Exactly. It's also considered appropriate for certain non-displaced complete tears, but only if the joint remains stable on testing, maybe less than 15 degrees of side-to-side variation compared to the other thumb, and, crucially, only if there's no evidence of a Steiner lesion.
Okay. No Steiner and relatively stable despite a tear.
Correct. The primary aim of this conservative approach is simply to protect the injured ligament and create the best possible environment for it to heal naturally.
Right, so what does that involve? Price protocol.
Spot on. Immediately after the injury, the Price protocol is vital for managing those acute symptoms. So protection is paramount. Yes, often with a thumb spica splint, or maybe temporary taping for a few days initially, just to immobilize the injured area. For grade 2 injuries, the immobilization period is longer, typically involving a custom-made thumb spica cast or a rigid splint worn continuously for around 4 to 6 weeks.
4 to 6 weeks. Okay. What about rice?
Yes, resting the hand for at least 48 hours is crucial initially. Then icing the thumb and hand promptly 10 minutes at a time, multiple times a day, helps minimize swelling and pain.
Wrapped in a towel, of course.
Of course, compression with a bandage can also help reduce swelling and provide some gentle support. And elevation of the hand above heart level, especially in the first few days, is important for drainage.
And pain relief.
Yes, over-the-counter pain relievers like paracetamol or non-steroidals like ibuprofen can effectively manage discomfort.
Okay, so protect, rest, ice, compress, elevate, and splinting for maybe 4-6 weeks for grade 2. What happens during that immobilization period?
Well, during this time, collaboration with hand therapists is really key.
Ah, the therapy team comes in early.
Yes. While strict immobilization is maintained to protect the healing ligament, some more progressive protocols might advocate for specific, very controlled active and passive range of motion exercises, sometimes even within the splint or at specific intervals.
Gentle movement to prevent stiffness.
Exactly. But it has to be scrupulously guided. Patients must avoid putting any undue stress, any valgus or varus force on that healing ligament.
Right.
And it's absolutely crucial to advise patients to avoid using the injured hand for functional tasks during this time, especially anything involving a strong pinch, spanning to open jars, grasping objects tightly, or lifting anything heavy.
So really protecting it is the main message.
Absolutely. Strict adherence is needed to prevent re-injury and allow robust collagen to form, letting the ligament heal properly.
And the outcomes with this non-operative approach.
For these grades, grade 1 and 2, and selected stable grade 3s without a Steiner, excellent outcomes are commonly achieved, including a high rate of return to sport without residual laxity or disability.
That's good to hear.
Yes, patients often regain full, pain-free function provided they stick meticulously to the protective measures and the rehab protocols afterwards.
It's good to know that many patients can achieve excellent outcomes with that conservative care, especially for those less severe injuries. But what about the instances where that's not enough, or the injury is severe right from the start?
Right.
When does surgical intervention become the preferred or indeed the necessary course of action?
That's the critical question, isn't it?
Yeah.
And it really gets to the heart of treatment decision-making. Surgery is often necessary for those grade 3 complete ligament tears, particularly when there's significant joint instability.
How do you define significant instability?
We generally define it as more than about 15 degrees of side-to-side laxity compared to the uninjured thumb, or maybe an opening of 30-35 degrees on stress testing, or, critically, that complete absence of a solid endpoint, that mushy feel again.
Okay, clear instability.
Yes. And as we've discussed, the definite presence of a steen or lesion is a direct indication for immediate surgical repair.
Because it won't heal otherwise.
Exactly. Spontaneous healing is impossible. Also, markedly displays avulsion fractures where that bone fragment is pulled off and significantly shifted. They also require surgical reduction and fixation.
To put the bone back and allow healing.
Correct. Furthermore, if a partial or even complete tear was initially managed non-operatively, but it continues to cause persistent pain and fails to heal properly after, say, 3 months of diligent immobilization and attempted rehab.
If conservative measures fail.
Exactly. Then surgery may be required as a secondary measure to address those ongoing symptoms and the instability.
Okay. So what does the surgery typically involve for an acute injury?
For acute grade 3 injuries, the standard approach is direct ligament repair.
Sewing the ligament back together.
Essentially, yes, or reattaching it to the bone. Techniques vary, but common ones include using transosseous sutures, passing stitches through tunnels drilled in the bone, or using suture anchors. These are small implants drilled into the bone with sutures attached, which then secure the ligament. Or sometimes direct repair of the ligament to the periosteum, the membrane covering the bone.
And the goal?
The goal is always anatomic repair, meticulously reopposing the ligament back to its native attachment site, restoring its original length and tension as closely as possible.
Makes sense.
For a UCL repair, we typically use an S-shaped or maybe a chevron incision over the MCP joint to get good access while minimizing damage to nerves and tendons nearby.
Okay. And you mentioned RCL injuries might have a lower threshold for surgery?
Yes, that's an important point for the radial collateral ligament.
Yeah.
Even a small displacement, sometimes as little as 1 millimeter of an avulsion fracture or the ligament's end, can lead to a poor outcome with non-operative treatment.
Why is that different from the UCL?
It seems the periosteum and other soft tissues on the radial side tend to get in the way more readily, intervening and physically preventing healing, even with small displacements.
Ah, okay. So more likely to need fixing even if it hasn't moved much.
Generally, yes. The threshold for offering surgery for an RCL injury can often be lower than for a comparable UCL injury.
Interesting. What about chronic injuries? If it's diagnosed late or the repair fails?
Right. In chronic injuries, meaning those older than perhaps 3 to 8 weeks, or if we find during surgery that the native ligament tissue is too poor, too incompetent, or scarred to be repaired directly.
If there's nothing good left to sew back together.
Exactly. Then a formal ligament reconstruction using a tendon graft might be necessary.
Using tissue from elsewhere.
Yes. The palmaris longus autograft, a spare tendon from the forearm, which many people have, is a common and excellent choice.
Okay.
We weave this tendon graft through bone tunnels in the metacarpal and phalanx and secure it with various methods like interference screws, cortical buttons, or suture anchors. The aim is to create a new, stable ligament.
Rebuilding it rather than repairing it.
Precisely. In some acute UCL ruptures, we might also perform an adductor advancement alongside the repair, reinforcing it, essentially. And for very chronic cases, or failed reconstructions, MCP joint fusion is a salvage option.
Using the joint solid.
Yes, typically fusing it in around 15 degrees of flexion to maximize functional pinch and provide stability, but obviously sacrificing movement at that joint.
A last resort, presumably?
Generally, yes. But the good news is that clinical outcomes after surgical treatment for both acute and chronic UCL injuries are consistently reported to be excellent.
Really? What did the study show?
Well, systematic reviews show excellent clinical outcomes overall. Studies report over 90% excellent outcomes for UCL repair, 96% good to excellent for RCL repair, and around a 92% satisfaction rate for reconstructions.
Those are very positive numbers.
They are. And complications, while possible, are generally rare. It underscores that surgery, when indicated, is a very effective and reliable intervention.
That's a strong endorsement for surgical intervention when it's necessary, particularly for those complete ruptures. And of course, surgery is just one part of the journey, isn't it?
Oh, absolutely.
The post-operative phase and the rehabilitation are equally, if not more, crucial for achieving that optimal functional recovery.
You're absolutely right. The success of the surgery is heavily reliant on a carefully structured post-operative and rehab program.
So what can patients and clinicians expect during this critical period?
Well, it's a phased approach. designed to protect the healing repair while progressively restoring function, movement, and strength.
Okay, so immediately after surgery.
Immediately after surgery, the thumb typically requires a period of immobilization. This usually starts with quite a bulky
For
cast.
protection and comfort.
Exactly. Worn for the first 2 weeks, generally. It provides substantial protection, helps minimize swelling. After 2 weeks, this is commonly changed to a lighter weight cast, often a thermoplastic splint. That's usually when the wound is checked, and any non-dissolvable stitches are removed. And patients are given strict advice to monitor their wound closely for any signs of infection, increasing redness, swelling, oozing, any bad smell, or if they develop a fever.
Important to catch infections early.
Vital. They need to contact their hand therapist, GP, or urgent care promptly if any of those signs appear.
Okay, so after the initial cast.
At around 4 weeks post-op, that lightweight cast is typically replaced by a custom-made plastic splint. This splint is absolutely vital for protecting the thumb during the continued healing phase, especially as they start some gentle movement.
And they wear this continuously.
Yes, usually continuously for at least another 2 to 4 weeks initially. Strict instructions. Don't remove it yourself. Keep it scrupulously clean and dry. Maybe cover it for showering.
Right.
Don't try and adjust it. Keep it away from heat sources that could warp it. And importantly, be aware of potential skin irritation or pressure sores. Contact the therapist if there's significant rubbing or redness.
Okay, so strict splinting for maybe 4-6 weeks total after surgery? Then what?
Then after that initial immobilization phase, the crucial work with the hand therapy team really begins in earnest.
This is where the active rehab starts.
Yes. A strict, specific exercise program, usually lasting a minimum of 12 weeks, is initiated. This is where the magic happens, really. Restoring movement, strength, function, but without jeopardizing the repair.
Following the therapist's instructions to the letter?
Imperative. Patients must follow the prescribed exercises meticulously. Avoid trying their own things, as any unguided stress could easily damage the still healing ligament.
So what kind of exercises are involved initially?
Initially, the focus is on regaining pain-free range of motion. Gentle stuff. This includes exercises like thumb IP, that's the end joint, and MP blocking.
Blocking? What's that?
That's where you use your other hand to stabilize one joint while moving the adjacent one. It isolates the motion, protects the repair site from unintended stress. Very important early on.
Ah, I see. Controlled movement.
Exactly. They'll also work on thumb extension and flexion, bringing the thumb out to the side, then back into the palm, thumb opposition touching the thumb tip to each fingertip, crucial for dexterity.
Right.
And other movements like thumb palmar abduction, moving the thumb forward away from the palm, and radial abduction, moving it out sideways. Maybe gentle thumb extension, lifting it off a flat table.
Small controlled movements, repeated often.
Typically 8-10 repetitions, 3-4 times a day. Gentle holds at the end of range. Controlled, careful movement.
And strengthening, when does that come in?
Strengthening exercises are gradually introduced as healing progresses and stability improves, usually around 6 to 8 weeks post-surgery.
What do those involve? Therapy putty.
Often, yes. Therapeutic putty of varying resistances is great. Exercises like thumb extension against the putty, thumb press into the putty, thumb adduction pressing putty against the index finger. These build intrinsic hand muscle strength. Then pinch strengthening exercises are initiated. Squeezing putty between thumb and index finger side, the three-jaw chuck pinch. Pulling putty with thumb, index, and middle fingers. Finger spread exercises.
Gradually building up the force.
Exactly. Typically 6 to 8 reps, minimum 3 times a day. It's this carefully phased approach that ensures the ligament is protected while it gradually regains resilience and functional strength. It allows for robust healing and ultimately a successful return to activities.
It sounds like a truly methodical and patient-led process, with the hand therapist really guiding them through what sounds like quite a lengthy journey.
It is. Patience and adherence are key.
Which leads perfectly to one of the most pressing questions patients always have. When can I get back to normal?
Yes, the million-dollar question.
What are the typical recovery timelines? And how do we guide patients safely back to their daily activities, including work and sport?
Well, recovery is definitely a significant process, and timelines do vary considerably. Depends on the injury severity and the management, of course.
Right.
For those mild grade 1 sprains treated non-operatively, healing can be relatively quick, maybe 4 to 6 weeks with proper rest and immobilization.
Okay.
However, for the more severe grade 3 injuries needing surgery, full recovery is a substantial journey. Often extending to 3 to 6 months before we're talking about a complete return to normal, unrestricted use.
3 to 6 months, that's quite a while.
It is. It accounts for the post-surgical healing, the casting, the splinting, and that extensive course of physical therapy.
And you mentioned the ligament stays weak for a while.
Yes, that's a critical point to communicate. The repaired ligament, even after surgery, remains biologically quite weak for about 12 weeks post-op.
12 weeks, so 3 months.
Roughly, yes, which necessitates that care for progressive protection. Patients are guided stage by stage by their hand therapist, gradually increasing the stress as the ligament matures.
So what can they expect to do and when? Light activities first.
Generally, yes. Light activities, things like personal care washing, shaving, light clothing fastenings, combing hair, tying shoes, that often becomes possible around 6 weeks post-operation.
Okay.
Other light things, too. Reading, cards, phone use, handling money, remote controls, basic writing, light dusting, light switches. Tasks needing minimal force, more precision than power.
Right. And medium activities.
Medium-intensity activities typically become feasible around 8 weeks.
What falls into that category?
Things needing a bit more grip or sustained effort. Holding a pint of liquid, a heavier cup, using scissors for general cutting, drying yourself with a towel, opening door handles, using keys. Driving often becomes possible around now.
Okay. Driving at 8 weeks potentially.
Potentially, yes, if they can safely operate the controls. Also, light domestic chores. Sweeping, unscrewing jars that aren't too tight. Hanging, washing up, wiping surfaces. Opening ring pull cans.
So maybe using the splint sometimes.
Yes. At this stage, for anything that feels strenuous or a bit risky, they might still be advised to use their splint for protection. Gentle hobbies like knitting or painting might also be cleared around now.
Got it. And the heavy stuff. Work, sports.
Right. Heavy manual work, gardening, carrying heavy shopping, lifting heavy objects, cleaning the car, decorating, and, crucially, high-impact or contact sports.
Golf, swimming, gym, cycling, football, rugby.
All of those are usually restricted until approximately 12 weeks post-operation.
The 3-month mark again?
Exactly. The repaired ligament really needs to be robustly healed before it can withstand those higher loads and potential impacts.
But the outlook for returning to sport is generally good.
It is, yes. The good news is that return to play rates after anatomic repair are notably high, approaching 100% in some reports, especially for recreational athletes.
That's excellent news for active patients.
It is. Regarding returning to work, office-based roles, light desk work, usually a return is possible in 6 to 8 weeks, perhaps with some ergonomic adjustments. Driving, as we said, typically cleared around 8 weeks. But manual work or intense sports activity will require that full 12-week recovery period, sometimes even a bit longer, to ensure the ligament has regained sufficient strength, endurance, and proprioception to prevent re-injury.
And liaising with the GP is important for managing time off work.
Absolutely. Clear communication with the patient's GP is always advised for sick notes, and coordinating a safe, effective, maybe phased return to all aspects of their life, ensuring recovery isn't jeopardized by doing too much too soon.
Those detailed timelines are incredibly helpful, I think, both for managing patient expectations and for guiding them safely back to their lives.
Yes, managing expectations is key.
Now, while the outlook seems largely positive with the right treatment, are there any potential complications that clinicians and patients should be aware of? And what does the overall long-term prognosis look like?
Indeed, while outcomes are generally favorable, complications can certainly arise, and we need to be vigilant. The most common, perhaps, is joint stiffness.
Stiffness from the
That's right.
immobilization.
Primarily, yes. Affecting both the MCP and the IP joint, the end joint of the thumb, it's often an unavoidable consequence of that necessary immobilization period. It can manifest as difficulty fully flexing or extending the thumb, impacting dexterity. Hand therapy is crucial to mitigate this, of course.
Okay. Stiffness. What else?
Persistent instability is another significant concern.
The joint remaining loose.
Yes. This has been observed in about 15% of grade 3 UCL injuries initially treated with immobilization alone.
Oh, highlighting why surgery is often recommended for those.
Precisely. Especially with a Steiner lesion. This persistent instability means ongoing laxity, the joint feeling like it's giving way, chronic weakness with pinch and grasp, and it often necessitates that secondary ligament reconstruction we talked about.
Other long-term issues?
Well, chronic pain in the thumb can be an issue, significantly impacting quality of life. And the development of degenerative arthritis in the thumb joint over time is a real risk, especially in cases of chronic instability or ligaments that haven't healed quite right.
Arthritis is a big concern long-term.
It is. A noticeable decrease in pinch strength is also quite common. And that's not just a test result. It means struggling with everyday tasks,
Hmm.
opening jars, tying laces, holding things securely.
Affecting daily function significantly,
Definitely. And post-surgical complications, though generally rare, must be considered.
such as.
Things like superficial radial neuropraxia, that's temporary numbness, or tingling along the back of the thumb from nerve bruising near the incision, usually resolves on its own over weeks or months.
Okay.
Very rarely, direct nerve damage can occur. Surgical site infections are possible, though uncommon. Skin necrosis is another very rare possibility with certain older techniques.
So overall prognosis, generally good if managed well.
Yes. In terms of overall prognosis, grade 1 and 2 sprains, managed correctly with rest, protection, rehab, they typically heal very well without long-term issues. The ligament regains integrity and function. For severe grade 3 UCL sprains, especially those with a Steiner lesion, surgical treatment is usually highly successful in restoring stability and function. The evidence consistently supports that surgery reliably restores that essential anatomical and functional integrity.
And untreated grade 3s.
Untreated grade 3 UCL sprains, particularly with a Steiner, are highly likely to lead to that chronic instability, profoundly impacting hand function. Because the UCL is just so key for stabilizing pinch and grasp.
So the evidence strongly supports surgery when indicated.
Yes, the systematic reviews confirm that surgical treatment for both acute and chronic UCL injury leads to excellent clinical outcomes, with complications being rare. It's a very effective intervention in the right circumstances.
That brings us to a crucial point then, prevention. Given the significant impact these injuries can have, what proactive steps can individuals take to minimize their risk? Beyond the obvious, what are the actionable insights?
Prevention, as always, is better than cure, isn't it? And actually, some simple proactive measures can significantly reduce the risk. Firstly, incorporating hand and finger muscle stretches into warm-up routines before any exercises or sports that heavily involve the hands.
Just simple stretches.
Yes, gentle wrist rotations, finger spreads, thumb circles. These can increase flexibility, improve joint mobility, prepare the ligaments and muscles, making them less prone to sudden tears.
Makes sense. What about equipment?
Wearing appropriate safety equipment during sports is also crucial. In some sports like baseball, hockey, American football, specific gloves or even taping techniques can provide some extra support and stability to the thumb, acting as a prophylactic measure against excessive hyperabduction.
Right. And skiing. The classic skier's thumb.
Yes, for activities with a risk of falls, like skiing, it's really advisable to consciously try and let go of ski poles if a fall is imminent.
Rather than holding on tight.
Exactly. That simple action can prevent the pole acting as that lever, forcing the thumb into hyperabduction. Many injuries happen because the pole strap prevents the hand from releasing.
The strap is the culprit often.
Often, yes. And furthermore, just general fall prevention is key. Exercising on flat, stable surfaces, making sure footwear fits well and laces are tied properly, helps prevent trips and falls onto that outstretched hand.
Basic safety measures.
Yes. And for individuals at higher risk of falling, perhaps the elderly or those with balance issues, using walking aids like a cane or walker provides essential support and stability, reducing the likelihood of sustaining this type of injury from a fall.
So these seemingly small preventative steps can make a real difference.
They really can.
Yeah.
Taken consistently, they can help avoid a painful injury and a very lengthy recovery.
Well, a fascinating and really comprehensive deep dive into thumb collateral ligament injuries. Your insights have truly eliminated the complexities and nuances of managing these conditions right from the diagnostic considerations through to the detailed rehab programs.
Thank you.
It just underscores how vital the thumb is to our daily function, doesn't it? And why that accurate diagnosis and a tailored treatment plan are absolutely non-negotiable for getting the best patient outcomes.
Indeed. Recognizing the specific type and severity is paramount. It directly dictates whether a patient is likely to recover well with conservative measures, or if they really need surgical intervention to avoid that long-term instability and dysfunction.
That difference between a partial tear and a complete rupture, especially with a Steiner lesion.
It fundamentally shifts the treatment paradigm, yes, sets the patient on a very different path.
Absolutely. And to you, our listener, we hope this deep dive has provided you with valuable takeaways for your clinical practice and understanding. If you found this discussion insightful, please do take a moment to rate and share Deep Dive Ortho with your colleagues.
Mm-hmm.
As we wrap up this deep dive into what might seem like just a small thumb injury, It really prompts reflection, doesn't it, on just how much of our human ingenuity, our work, our art, our very connection to the world flows through the incredible dexterity of our thumbs.
It's quite profound when you think about it.
Perhaps the real deep dive here is into understanding how profoundly even a seemingly minor injury can disrupt not just a joint, but a life, underscoring our vital role in restoring that fundamental connection. Thank you for joining us.
Thank you.
Until next time, keep exploring, keep learning, and keep asking those incisive questions.